Let's talk about the sample long case of systemic sclerosis. Mrs. Jobeda Khatun, a 35-year-old woman hailing from Mymensingh, presented with the complaints of shortness of breath for last 6 months, which is insidious in onset, gradually progressive, initially present only after moderate to severe exertion, but for the last 1 month, breathlessness is present even after mild exertion. The breathlessness is so severe that it is hampering her daily activities, such as going to the toilet, moving across the room, and dressing, undressing. This is associated with dry and distressing cough. There is no history of chest pain, any orthopnea, or paroxysmal nocturnal dyspnea. With those complaints, she visited several physicians and took some medications, but it didn't improve her symptoms. Then she was referred to BSMMU for further management. In the year 2001, she was diagnosed with a case of systemic sclerosis on the basis of progressive thickening and tightening of skin, initially involving her both hands, then gradually involving her feet, and then progressing to involve up to elbow and up to the knee. At the same time, she also developed symmetrical inflammatory polyarthritis involving her both hands and feet. Then she was prescribed tablet methotrexate 7.5 mg and tablet prednisolone for a few weeks, with which her joint pain and swelling partially improved. In the year 2009, she developed weakness of her all four limbs, predominantly involving the proximal limbs. It's evident by difficulty to raise her hands above the head level and difficulty in standing from sitting position. She was hospitalized and was prescribed an intravenous medication for 3 days. This was most probably intravenous methylprednisolone. After hospital admission, she was prescribed for prednisolone again, and this was tapered gradually to a dose of 5 mg per day. Till then, she is taking tablet prednisolone 5 mg daily without any significant adverse effect, such as obesity or weight gain, diabetes, or osteoporotic fracture. After that, her disease goes on multiple relapsing and remitting courses till this current episode of shortness of breath. On query, she informed that she was labeled as a case of hypertension in the year 2013. Until then, she is taking tablet amlodipine 5 mg daily. During her disease course, she had history of alopecia for last 5 years, occasional photosensitive skin rashes, 3 episodes of painless oral ulceration, occasional heartburn, and sequential color change on exposure to cold. But she had no history of seizure, unconsciousness, difficulty in swallowing, postprandial abdominal pain, alteration of bowel habit, oliguria, body swelling, fever with weight loss, or low back pain. She had no past illness like diabetes, thyroid disease, or other autoimmune diseases. There is no such illness in her family. She is a divorcee for the last 10 years. She used to take barrier methods while she was with her husband for the initial years. She had no child or any adverse pregnancy outcomes. She is regularly menstruating with a 28 days of menstrual cycle. She was not vaccinated before starting the DMRDs or thereafter. She felt occasional apathy and loss of drive, but she never felt any suicidal tendency. This is all about my history. On general examination, the anemia is difficult to see. There is non-scarring alopecia, shiny skin with loss of wrinkling on forehead, multiple hyper and hypopigmented lesion giving rise to salt and pepper appearance of face, pinched nose, and microstomia, puckering of lips around the mouth, thickening and tightening of skin up to both elbow and both wrist, JVP is not raised, and there is no thyromegaly or bipedal edema. Other general examination findings, including vitals, are within normal limits. On musculoskeletal system examination, there is fixed flexion deformity involving her both hands, sclerodactyly involving her both hands, evidence of nail fold infarction, both hypothenor and thinner wasting, telangiectasia involving palms of both hands, mild tenderness in both wrist joints. Both active and passive movement are grossly restricted in MCP and PIP joints of both hands. Functional capacity is grossly impaired. On examination of chest, there is bibasal crepes unrelated with cuffing from 7th intercostal space to downwards along the dorsal scapular line. On examination of precordium, there is no evidence of pulmonary hypertension. Fundoscopic examination reveals there are multiple hard exudates in both eyes. There is weakness in both upper and lower limbs involving proximal group of muscle, evident by muscle power MRC grade 4 in the proximal group of muscle with normal sensory. This is all about my history and examination. So my provisional diagnosis is diffuse parenchymal lung disease due to systemic sclerosis with proximal myopathy, or we can also say diffuse parenchymal lung disease with proximal myopathy due to systemic sclerosis or systemic sclerosis and SLE overlap. So this is my history and presentation. Now let's go back to the history and try to find out why I am explaining the case like this. First of all, the patient has shortness of breath. Now we are trying to explain the shortness of breath. We are trying to say about its onset. It's insidious in onset, gradually progressive. Then we mentioned about its grade, which is initially on moderate to severe exertion. Then it's present even after mild exertion. And we have explained how it's hampering her daily life. Then we have mentioned about cough, and the cough is dry, and that's all about cough. But we have mentioned that it's not associated with chest pain, palpitation, or orthopnea or PND. That means this is not a cardiac cough. This is not due to left ventricular failure. Then we have gone back. We have gone to 2001, where she was diagnosed, and then we have mentioned why she was diagnosed as a case of systemic sclerosis. And the basis were, first of all, there is thickening and tightening of skin, and also there is inflammatory polyarthritis. So we mentioned those 2 points. Those are the 2 points on the basis of which she was diagnosed. And whenever we talked about thickening and tightening of skin, then you say that this initially involved hands and then gradually progressed to involve up to elbow. Then we talked about the treatment, that she got some medications, methotrexate and prednisolone, for a few weeks. And after 2001, we went to 2009. In 2009, she developed a proximal myopathy, and we have mentioned why it was proximal myopathy. It was evident by difficult to raise her hands, above the head level, and difficulty in standing from sitting position. Then we mentioned about the hospital course. She was hospitalized for this. She got this medication, and then she were on this medication. And after that, her disease course goes on for relapsing and remitting courses. And she also developed hypertension. We mentioned the treatment of hypertension. Along with those history, we also mentioned some another positive side of the history, which is the history of SLE, alopecia, photosensitive rash, and oral ulceration. That means that the patient probably might have SLE along with the systemic sclerosis. But she had no history of, so we have excluded some important negative findings which is present. I forgot to mention that I also mentioned that the patient has heartburn, which is present in systemic sclerosis, and sequential color change on exposure to cold. That means the patient had Raynaud phenomenon. Then the negative histories, history of CNS involvement such as in SLE, seizure, and unconsciousness, history of esophageal involvement in systemic sclerosis, which is difficulty in swallowing, postprandial pain, which is due to vasculitis in the mesenteric vessels, alteration of bowel habit, which is due to small intestinal bacterial overgrowth, oliguria body swelling, which can happen due to the scleroderma renal crisis or kidney involvement, Fever with weight loss, which is a common finding. Fever can be present in the all common types of arthritis and systemic disease. Then we have went to talk about the past illness, the personal history, the vaccination history, and some psychiatric history. Then on examination, we have divided the examination into general and systemic. In systemic examination, we focused on mainly two areas, musculoskeletal and examination of chest. In general examination, we have found the classic features of SLE, where you have tight eyes, so it's very difficult to see the anemia, and you have multiple features on the face, starting from the alopecia. There is alopecia, which is not classic for systemic sclerosis, but you can see as you often have overlap between systemic sclerosis and SLE. And then you have shiny skin, very important. Skin is very shiny and tight, and loss of wrinkle in the forehead, multiple hypo and hyperpigmented lesion giving rise to a salt and pepper appearance. Nose is pinched, the nose is pinched and beaked, also called the beak nose. Oral cavity or mouth is small, so this is called microstomia. There is puckering of lips, microstomia, puckering of lips around the mouth, thickening and tightening of the skin on the hands up to elbow, and in the legs up to both knee. JVP not raised, and there is no thyromegaly. On musculoskeletal system, you have look, feel, move. So in look, you have the fixed flexion deformity and the sclerodactyly. You will also have nail fold infarction, thinner and hypothinner vesting, and telangiectasia. So this is the look. And then you feel, and when you feel, you have mild tenderness. Then you have movement. The movement is grossly restricted. Chest examination is supportive of the DPLD, diffuse parenchymal lung disease. You have found what? You have found the bibasal, I think it's better to say fine end inspiratory crackles. Bibasal, fine end inspiratory crackles, unaltered with cuff from 7th ICS to downwards along the dorsal scapular line. On examination of precordium, there is no evidence of pulmonary hypertension, which is like you will not have, you don't have any left parasternal lift or palpable P2, etc. And fundoscopy examination reveals hard exudates, which may be evidence of disease. Maybe diabetes, I don't know. Maybe she has background of diabetes. There's weakness in both upper and lower limbs involving proximal group of muscles, which is supportive of proximal myopathy. So that's all. That's my case of systemic sclerosis, DPLD due to systemic sclerosis, or DPLD due to systemic sclerosis, SLE overlap.